All right, everyone. Thank you. Thank you for joining another CSO webinar, journal club this time. It's one of our journal clubs that can go globally relevant topic. This time, we are going to talk about the SUPREMO trial, which is describing results from a large trial looking at post-mastectomy radiation. But before we get to the trial discussion, the journal club, I want to describe what we do at CSO Oncology. CSO is otherwise called Common Sense Oncology. We are focusing on three pillars. The core pillars of our work are focusing on three E's. One is evidence generation, and that part is about ensuring appropriate clinical trial use and reporting. The second part is evidence interpretation, and that is what we are doing here, which is fostering critical thinking in oncology. And the third pillar is evidence communication, that is improving patient, public, policymaker understanding of cancer treatment options. CSO Oncology was founded in Queen's University in Canada, but it's now a global movement spread over at least 3 or 4 continents. We have chapters in India, Australia, Europe, and North America. So this session, we have in attendance Dr. Angela Eapen, who will present the trial findings from the SUPREMO trial, which was presented in New England Journal of Medicine a few months ago. Dr. Sushil Beriwal, a radiation oncologist and Vice President of Varian, and a faculty in Allegheny General Hospital, formerly faculty in UPMC Pittsburgh, will discuss the trial results in the setting of the overall clinical practice patterns across the world. Dr. Shafeek Shamsudeen is a breast surgeon and an oncoplasty surgeon practicing in Kerala. He's highly regarded as a very astute interpreter of critical thinker of evidence. So I look forward to hearing him speak about the surgical aspect of the study. And finally, we have Professor Seema Gulia from the Tata hospitals who will discuss the medical oncology perspective of the study. My colleague, Dr. Manju Senkar, is also leading the effort of CSO Oncology in India. She's also here in attendance. Thank you, everybody, for joining us. We will be releasing this in YouTube, so you can catch up on those parts you miss once it's released. But now let me invite Dr. Eapen. Angela, can you present the study so that we can then get into the discussion? Thank you.
Hi and good evening, everyone. Thank you for the kind introduction, and I'm really happy to be opening this journal club session. To start with, in daily practice as radiation oncologists, it's almost a reflex for us to recommend post-mastectomy radiation for patients with intermediate risk breast cancer. But today, we are going to discuss the highly debated results of the SUPREMO trial, which asks the question whether chest wall irradiation truly affects the outcomes in intermediate risk breast cancer patients, and also whether this should be reserved for some and not all of the intermediate risk breast cancer patients. So just to briefly give the historical background, for post-mastectomy radiation, the history comes from the Danish and the Canadian trials, in which breast cancer patients, node-positive patients, underwent post-mastectomy radiation, and they found two things. One is it reduced the risk of locoregional recurrence, and the second thing was that it improved the 10-year overall survival. So this established not the fact that radiation not only allows local control, but can also translate into an overall survival in this subset of patients. Coming to the EBCTCG meta-analysis, which is a pooled analysis of all these studies, including the Danish and the Canadian studies, the EBCTCG showed that there was a dramatic reduction in the 10-year locoregional recurrence in those who received post-mastectomy radiation from 21% to 4.3%. That was an absolute reduction of about 16.7 percentage. And this at 20 years translated into an overall survival or a reduction in breast cancer mortality of about 7.9%. And we got the 1:4 rule, which we've all read about. That is, for every 4 local recurrences prevented, 1 breast cancer death could be avoided. But there were certain limitations with this data. One is the temporal constraint. That is, These studies were done at a totally different era and a different oncology landscape. So a lot of therapies have evolved since. There has been evolution of systemics, a lot of genomic and biological subtyping happening, and even in terms of pathological granularity, now we don't just look at the stage of the disease. We look at the genomic assays, the receptor status, the lymphovascular space invasion, and so many more things. So which are looked at in the newer studies. So that brings us to the clinical dilemma that while post-mastectomy radiation is clearly benefiting high-risk patients, is there enough absolute benefit to justify the routine use of post-mastectomy radiation in patients with 1 to 3 positive nodes or those node negative with high-risk features? A bit about the trial. So it was a large randomized phase 3 trial, and the recruitment began in 2006 and completed by 2013. A lot of countries and participating centers were involved with the central pathological review, and the 10-year follow-up was reached at 2023 and was published in the NEJM in 2025. Which patients were eligible? So they included unilateral non-metastatic stage 2 intermediate risk breast cancer patients, post-mastectomy, those with DCIS in the ductal carcinoma in situ in the same breast who were previously treated with surgery but have not received radiation for any cause whatsoever were also included. And those who were given contralateral prophylactic mastectomy were also eligible. So among the stage 2 intermediate risks, we had the PT1N1, PT1N2. We also had PT2N0 with high-risk features like grade 3, lymphovascular invasion, or both. And even the PT3N0 was also included in the SUPREMO trial. In the later on revisions of the trial protocol, they even included those who had taken neoadjuvant chemotherapy. And as for surgery concerns, they needed a minimum margin clearance of 1 millimeter or more. Those who were planned for immediate breast reconstruction were eligible. And as for the nodal staging, the SUPREMO trial employed axillary lymph node dissection, and it required a level 2 axillary clearance of a minimum of 8 nodes or more. In the initial protocol, it was 10 nodes or more, and then it was revised to 8 nodes or more. And for those who were N0, the axillary staging included sampling of 4 axillary nodes, sentinel lymph node, or an axillary lymph node dissection. Coming to the study design and randomization, so we are looking at the patients post-mastectomy who underwent a central pathology review, and this was to exclude any differences in regional practices. Fine. So it was a 1:1 randomization, very straightforward. They had one arm that was the chest wall irradiation arm, and the other arm was those who were not subjected to chest wall irradiation. And in both arms, there was the use of adjuvant systemic therapy. As for details of the chest wall irradiation, the doses offered were 40 gray in 15 fractions, hypofractionated RT, and as well as 50 gray in 25 fractions. And for interest to the radiation oncologist, the chest volumes included the chest wall, skin flaps, and soft tissues, 5 mm below the skin to the deep fascia. And regional nodes were not mandatory, it was discretionary. And we will look into the data of the regional nodal irradiation as well. But this was a study that mainly focused on the use of chest wall irradiation between the two groups. So they finally randomized 1,679 women. And after exclusion for different criteria, we had 808 in the chest wall irradiation arm in the intention to treat analysis. And we had 799 women in the no chest wall irradiation arm. So let's have a look at the baseline characteristics. If you look at it, they were well balanced between the two groups. let's just take a look at the histological grades. So majority, as we had talked about, were in the grade 2 and 3 histologies. And coming to the molecular subtype, as you can see, majority had a good biological subtype. They were around 517 in the chest wall irradiation group, had ER positive, HER2 negative, and as it was well balanced with those who did not receive chest wall irradiation. So this actually tells us that most of the women included in the study had a very good biological subtype, and they are often the hormone positive types are known only for late recurrences, and the study follow-up period, probably when we look at the results, we'll realize not long enough to uh, tell about the effect of chest wall radiation on this subtype. And as for the breast cancer staging, you had those stages were also well balanced. Here you can see that T2N1 and T3N0 were also taken into account. T2N1 is one stage that we would automatically, at least in my center, we would recommend post-mastectomy radiation for. So they were actually questioning the benefit in these groups, T2N1 and T3N0, which we would otherwise reflexively recommend radiation for. And the median number of nodes that were examined were 14 nodes for the lymph node dissection. And the total number of nodes involved, you can see that there were almost 190 to 200 patients in both groups with no nodes involved. And even for one node involved, we had about 300 patients in both groups, which shows a very low risk, sorry about that, which shows a very low risk nodal burden disease that we are dealing with while looking into the details of the study. Almost the axillary lymph node dissection was the main. In the SUPREMO study, all the patients underwent an axillary lymph node dissection, and those with N0 were subjected to sentinel lymph node or axillary sampling. You can see that almost all, around 600 to 650 patients in both groups received adjuvant systemic therapy, chemotherapy of some form, and they all received endocrine therapy and also other therapies like trastuzumab, anti-HER2 regimens. And coming to the study, the follow-up period was 9.6 years. And earlier I had told you about the regional nodal irradiation. So it was not mandatory. It was subject to what the centers practiced. So for supraclavicular lymph node irradiation, 12% gave supraclavicular node RT along with chest wall irradiation. About 1.5% gave internal mammary radiation. And as for the group that was not offering chest wall irradiation, only 1.5% treated with supraclavicular and 0.9% with internal mammary. Coming to the primary endpoint, as you can see, the overall survival, the Kaplan-Meier curves show that the overall survival is almost similar in both the chest wall irradiation and the no chest wall irradiation groups, with a 10-year overall survival of 81.4% in those who received chest wall irradiation and 81.9% in those who were not subjected to chest wall radiation. So this came with a hazard ratio of 1.04, and the p-value was not significant, showing that there was no overall survival difference between the group that received chest wall irradiation and that which did not receive the chest wall irradiation. Similarly, the secondary endpoints were chest wall recurrence, locoregional recurrence, distant metastasis-free survival, and disease-free survival. There was no difference in the two groups in terms of significant difference in terms of chest wall recurrence, locoregional recurrence, distant metastasis-free survival, and disease-free survival. We can see that all the curves are overlapping, but here I would like to mention, if you look at the left side of the slide, in chest wall recurrence, you see that the chest wall irradiation group, it was 9 out of 808. And in the no chest wall irradiation, it was 20 out of 799 patients. So there was some effect here. Radiation actually lowered the hazard of chest wall recurrence. It has almost halved it, although not significant. So I was just thinking, and even on reading up, that probably preventing a chest wall recurrence or a salvage is it preventing that can lead to less morbidity for the patient and also a lot of psychological trauma of having to go through a chest wall recurrence treatment. So this is probably the only effect that was observed here. Besides that, all the curves are overlapping, and there was no difference between the chest wall irradiation and no radiation group in terms of locoregional recurrence, distant metastasis-free survival, and disease-free survival. As for the forest plot that is displayed here, I'd like to mention that they had a pre-planned subgroup analysis to study overall survival and the effects on overall survival when we look at age, the nodal status, and molecular subtype. And it was similar across all groups for both chest wall irradiation and those who did not receive radiation. The only thing to note here is that the triple negative subtype showed a hazard ratio of 1.91. That is, those who did not receive chest wall irradiation had had a better overall survival, which is actually counterintuitive to what we already know of being a very biologically aggressive disease. So the authors say that this is probably because of the low number. We had only very few, about 11 patients of triple negative subtype, leading to a very biased data. So otherwise, in the pre-planned subgroup analysis, there was no difference based on age, nodal status, and the other molecular subtypes. The safety profile, the lung-related adverse events, the incidence overall was less than 2% with chest wall irradiation. And this was probably the only bigger number in terms of adverse event was the lung-related adverse event, which was more in the chest wall irradiation group. Otherwise, the cardiac mortality and the lung cancer mortality was almost similar, and there were no it was identical across both groups. So coming to the discussion points, which I will leave to the experts for the consensus at the end. The SUPREMO trial supports a very selective, individualized approach to chest wall irradiation. There was no significant improvement in the overall survival, locoregional recurrence, disease-free survival, or distant metastasis-free survival in intermediate risk patients. And this included pathological N1 as well as high-risk pathological N0 patients. And high risk includes large tumors, those with LVI grade 3. To note is that chest wall recurrence was already very low even without radiotherapy. That is, it was less than 3% at 10 years. And the small benefit of chest wall irradiation declines with the improvement in systemic therapies. That is, both the groups were subjected to systemic therapies, and the systemic therapies have good contribution to the high numbers of overall survival and that we have seen. So they have termed this as a threshold effect, that it's probably because of the systemic therapies which have already conferred a good benefit. And the pre-planned subgroup analysis showed no difference except in T and BC, which we already discussed. And regional nodal irradiation may remain important, while routine chest wall irradiation may be avoided for many intermediate risk patients. But as a radiation oncologist, I think we take this with a hint of skepticism. But just a last slide on limitations. The trial was initiated nearly 20 years ago in a completely different oncological landscape. Many of the patients whom we term as these intermediate risk patients were included in this study would have been subjected to neoadjuvant chemotherapy in today's practice. And in the SUPREMO, the primary management of axilla was by axillary lymph node dissection, which has now moved from that to more of sentinel lymph node biopsies, de-escalation treatments, and even axillary radiation. So We and the risk stratification, which was earlier based on staging alone, is now based on the biological subtype, the receptor status, grade, lymphovascular invasion, genomic risk, and nodal burden. And of course, a very important point notice: 10 years, just to note from the EBCTCG meta-analysis, 10 years may be a short period to make any definite conclusions, because even there, the result of the loco-regional recurrence rates that was observed at 10 years eventually translated into a survival. So probably it is too early to make definite conclusions. And as I had already mentioned, majority of the cohort were ERPR positive, HER2 negative patients that usually do very well on other therapies and have late recurrences. So probably these patients have to be looked into with time to see if any change will be brought about in the results. Thank you.
Thank you, Angela, for a very succinct and to the point presentation. You described all the positives of the trial, the design, as well as the limitations according to your perspective. May I invite Dr. Beriwal, a very renowned radiation oncologist, a teacher of teachers, to provide us your critical input on this study conclusions.
Okay, let's see. So is the screen visible?
Yes, it is.
Good. So, Dr. Angela gave a good presentation on SUPREMO trial. I'll try to highlight some of the important caveat of the trial and then explain in context of what we do nowadays to understand the difference between the SUPREMO trial and how it adapts to our practice in 2026. First of all, the trial was designed chest wall radiation versus no radiation. I just want to emphasize almost all modern clinical trial for post-mastectomy radiation therapy include regional nodal radiation therapy, which was excluded from the trial. And I'll explain the significance of that as we go along. Second of all, like the sample size was reduced and the trial was designed to power 7% difference in overall survival. That's very overzealous for any post-mastectomy radiation therapy trial. And I'll explain again, as we talked about Oxford meta-analysis, why this was overzealous even to think about it in terms of outcome. Now, about 1 in 4 patients were node negative T1, T2 disease, which I would not even consider intermediate risk. They are probably low risk disease. Majority had N1 disease, as pointed by Dr. Angela. And among N1 also, majority had 1 node positive, which again did not distinguish between micrometastasis and macrometastasis, because N1 micrometastasis is more treated like N0 disease in terms of post-mastectomy radiation therapy. So to answer your question, that majority of the patients were node positive, but not an insignificant number were either node negative or were also micrometastasis, which do not benefit from post-mastectomy radiation therapy. T3N0 was very small number, less than 1% of the overall group. So 1 to 3 node positive considered 40% with both single micro and macrometastatic disease, which was not distinguished between the trial. The lymph node dissection was done in all. And as Dr. Angela mentioned, in 2026, we don't do dissection in any one of these patients which were present in the SUPREMO trial. The practice pattern has completely changed. And based on the guidelines and the available data, which I'll discuss, lymph node dissection has higher morbidity in terms of lymphedema, in terms of shoulder pain, with no difference in outcome compared to radiation therapy. So we have to also look into that context, that de-escalation therapy is the way to go for breast cancer in terms of local regional treatment. But when we talk about de-escalation, is omitting radiation therapy is the right de-escalation in lieu of surgery is an open-ended question. But that being said, almost all the studies which have looked at surgery versus radiation have shown increased lymphedema, which can impact quality of life. Now, these were the endpoints of the trial. And I just want to point out, there was small, insignificant difference, small, statistically significant difference in chest wall recurrence. It may or may not be clinically significant. And the number was, as pointed by Dr. Angela, was less than 2%. So overall, the way the trial was designed showed small difference in chest wall recurrence, no difference in disease-free and overall survival. And the trial concluded that for this subset of patients, we don't need post-mastectomy radiation therapy. Now, what do you mean by regional node radiation therapy? The regional node radiation therapy, by definition, is undissected axilla, level 3, medial and or lateral supraclav, and upper IMN node. In modern day context, when we treat regional node, we almost always include undissected axilla, level 3, medial supraclav, and plus upper IMN node as part of the treatment. And that's what regional node radiation therapy constitutes, which was not done in the SUPREMO trial. Now, the SUPREMO trial was designed to see 7% difference in overall survival. And just to give you the context, in 2023, Lancet published Oxford meta-analysis of 16 trials, out of which 8 were modern trials, so 14,000 patients. When they looked at 14,000 patients, the decrease in breast cancer mortality was 2.7% at 15 years for N1 disease. To expect for low-risk disease or intermediate disease without regional node radiation therapy to see 7% difference in overall survival, that's not happening. Now, also important to realize is that the breast cancer mortality took long time to appear also, just because of the fact it takes significant years to see translation of decrease in distant mets to translate in breast cancer mortality because of effective salvage treatment some of these ER-positive breast cancer patients have. Also emphasize the fact in the newer trial, because of modern technique, there is no increase in non-breast cancer mortality, which was a problem in the previous clinical trial, because we are able to reduce the hard dose significantly to about 1 gray or less. So the non-breast cancer mortality went down, and that's why breast cancer mortality and overall survival is improved. So in the 8 newer trial, local regional recurrence was improved, breast cancer mortality was improved, distant mets were improved, and overall survival is improved. So it's important to understand from the context for N1 disease. Now, Dr. Angela presented 4:1 ratio for the Oxford meta-analysis, and I questioned that ratio in the modern trial. When we talk about modern studies showing low local regional recurrence and saying, oh, we don't need radiation therapy, I think that's overinterpretation of the information. If you look at the 2 modern trials, the NCI Canada with and without regional node and EORTC with and without regional node, look at the difference in regional recurrence, 2.5 versus 0.5. But look at difference in distant mets, about 4% difference in distant mets and about 5% difference in DFS. So I always educate in the modern era, we should not be using that 4:1 ratio. Look at the ratio here is almost like 1:1 or even better than that, because not all regional recurrence manifests itself as local regional recurrence. That's number one. Secondly, the thought process is that regional persistent disease in the regional node is the reservoir for micrometastatic disease, which can increase the likelihood of distant mets and decrease breast cancer mortality, and regional node radiation therapy helps with that. So the ratio in the modern era, 4:1, should not be looked at. We should more look at what is the impact of that local regional decrease in distant mets and overall survival. And you can see from the NCI study that small difference translates into 1:1 ratio, not 4:1 ratio. That's very, very important context. Similarly, if you look at EORTC, which is 10 years data now, at this Easter, they will present 15 years data, and we're interested to see what 15 years data shows. It allowed mastectomy also, and with and without regional node, or for post-mastectomy with and without chest wall plus regional node. And again, they treated undissected axilla, supraclav, and upper IMN. And you can see, again, the same theme, 2% difference in regional recurrence. But that translated into improvement in disease-free survival and breast cancer mortality. So overall, if you look at these 2 clinical trials, the difference in local regional recurrence was small, but that translated into significant difference in distant mets and breast cancer mortality. And we need to always look from that context that larger studies, 14,000 patient Oxford meta-analysis, led us to see difference in breast cancer mortality and overall survival. So the studies which include low-risk disease, power to see 7% difference in overall survival would never translate into that kind of mortality difference as we're anticipating or expecting. Now, let's look at the modern ASCO guideline for post-mastectomy radiation therapy for people who undergo upfront surgery. Let's exclude this because that's not part of the discussion. For T1, T2 node margin negative disease, the recommendation is no PMRT. So there is already an existing recommendation for no PMRT for T1, T2 N0 disease, which constituted 25% of the patients in the SUPREMO trial. For T3 N0, in our own practice also, we offer post-mastectomy selectively for high-grade disease, for LVSI, for triple negative disease, or multiple adverse factor. So even this is also conditional. Now, for N1 disease, post-mastectomy is recommended, but there are caveats listed in the paper that not routinely everybody needs to get it. There are pros and cons of the approach, and I'll talk about that. So about 1 in 4 patients which were included in SUPREMO trial are already recommended no radiation therapy. And for N1 disease, I'll talk about the caveat of it. So for T1, T2, no radiation therapy or no regional radiation therapy. T3 and 0 is conditional. And I would just want to also add, based on the available data for T1, T2, N1 mic disease, which SUPREMO did not distinguish, we don't offer post-mastectomy radiation therapy. So already a sizable population which were included in SUPREMO trial when it was designed are not offered post-mastectomy radiation therapy. So that reduces the power of the study to see any difference between N1 disease, which we are going to talk about today. Now, for N1 disease, the rationale for treating is MA20, EORTC, Danish, and the Oxford meta-analysis. And the downside is SUPREMO trial, but I would be very cautious in looking at low local regional recurrence in modern patient because, as I mentioned, that 4:1 ratio is the thing of the past. The ratio is much more different. The small difference in regional local recurrence translates into improvement in breast cancer mortality. We have to always look from that context. So when we talk about N1 disease, one important caveat is axillary lymphodissection versus central for biopsy. In United States, hardly anybody undergoes lymphodissection for N1 disease. So once they have sentinel for biopsy positive, whether it's micromets or macromets, 1 or 2 node positive, they don't undergo dissection anymore. So that is important information which has changed the practice pattern post SUPREMO. The receptor status is important, age is important, LVSI is important, extracapsulation extension is important, and genomic assay like oncotype is important, which is part of the Taylor RT study. So we don't routinely offer all N1 patient post-mastectomy radiation therapy. We look at other factors. But one of the important practice pattern change between now and what is mentioned in SUPREMO trial is lymphodissection versus sentinel for biopsy. And why do we talk about it? These are 4 prospective studies which have shown that for 1 or 2 node positive disease, we do not need dissection. The largest of one is the Senemex study, 2,700 patients. You can see they were randomized to sentinel for biopsy alone versus lymphodissection. 90% of the patients received regional nodal radiation therapy. So in essence, in almost 90% of the patients sentinel for biopsy arm had regional nodal radiation therapy. If you look at the additional node positivity rate was 35%. But despite that fact, there is no difference in axillary recurrence. There is no difference in disease-free survival. But look at it, there is significant less arm pain and edema. So for patients with 1 or 2 node positive disease, the study showed no difference in any one of the breast cancer endpoint, but less arm pain and edema by avoiding dissection. That's important when we talk about de-escalation therapy for women with breast cancer because this can impact their quality of life. So if you look at NCCN guideline, that also lists that. If you have lumpectomy done and have 1 or 2 node positive, they'll get whole breast radiation therapy, don't do dissection. If you have mastectomy done, when they may or may not get chest wall radiation therapy, if they're micromets, don't do dissection because T1, T2 micromets doesn't need any additional treatment. If they have mastectomy done and 1 to node positive, adjuvant RT is planned, avoid dissection. So this is a discussion with the patient because if you give patient the option of risk of lymphedema or arm pain versus some impact on reconstruction vis-a-vis 3 weeks of radiation therapy, depending on the choice of the women and the impact of that intervention on patients' quality of life, they may choose one over the other. So it's not yes or no answer. And in our own experience and practice pattern, majority of women do not opt for axillary for dissection because of risk of lymphedema. So it's important to understand the caveat. So if I talk about SUPREMO in the context, majority are low risk, not intermediate risk, to whom we don't offer post-mastectomy radiation therapy. They offered only chest wall radiation therapy without regional node, which negates the advantage of post-mastectomy radiation therapy because in almost all modern trial, regional node radiation therapy has been used and has shown to decrease regional recurrence, which has translated into breast cancer mortality and overall survival in the meta-analysis. So in my mind, most patients with SUPREMO study would not qualify routinely for post-mastectomy radiation therapy. And surgical management has changed from sentinel for biopsy to only to no dissection of N1 disease. So if I conclude, T1, T2, N0, margin negative, don't need PMRT. T3, N0, which was a small part of SUPREMO inclusion criteria, do selectively based on multiple risk factors. T1, T2, N1 micromets, don't do regional nodal radiation therapy, don't do dissection, don't need post-mastectomy radiation therapy. PMRT for N1 based on other factor, but always need to include regional node, just not chest wall radiation therapy. If they have axial lymph node dissection done, then do selectively based on the risk factor. But the practice has changed. We don't do lymph node dissection because of risk of lymphedema. So for these patients with 1 to 2 cm biopsy positive macrometastasis, till other studies which come out, which shows we don't need any regional treatment, we need to offer regional nodal radiation therapy with chest wall treatment. And impact of ALND or lymphedema and the pain and discomfort should be weighed against the RT impact or reconstruction when discussing with the patient. Thank you.
Thank you, Dr. Beriwal. That was a masterclass. Just the same way I once used to be a resident a long time ago. Masterclass indeed. Let me get my surgical colleague, Dr. Shafeek Shamsudeen, to weigh in on the trial from a surgical oncology perspective. Thank you, Shafeek.
Thank you, Team CSO. Am I audible? Is my screen visible?
Yes, all good.
Okay, so over the next few minutes, I will try to focus on the surgical aspects, rather try to contextualize this whole trial, which has been beautifully dissected out by my previous two colleagues who have done a wonderful job in dissecting out the trial with its details. So my mandate, I understand, is to bring out the surgical implications of all these findings. So some of the key principles which I would like to highlight up front is that successful treatment de-escalation, we are talking about de-escalation more and more almost every day, including this trial, requires multidisciplinary consideration of the effects on the entire treatment plan, not just one modality. And number two is patient-reported outcome measures determine which therapies patient prefer to de-escalate, as we increasingly face a choice of which therapy to omit. And if you note in the trial, there was a small but measurable difference in the patient-reported outcome measures, which is quite significant clinically. Now, the driving force behind any de-escalation attempt is to minimize treatment-induced complications without compromising survival. And lastly, it is crucial to consider surgery and radiotherapy together because they share anatomical targets. And the aim of reducing locoregional recurrence is also a common aim. Yeah. So the first point I have to make is that real-world implementation of trial findings is challenging if the current clinical practice has changed. Now, a lot of aspects in the with regards to the change in the clinical practice has been brought out in the previous presentations, but I would like to focus on few. The first thing is regarding the concept of mastectomy itself. So we are now in an era, if you look at most of the recent consensus conferences and large oncology conferences like the St. Gallen, the discussion in the surgical side goes more towards preventing unnecessary mastectomies. And why should we prevent unnecessary mastectomies? Because it's simply not a good oncological operation. There is no evidence of better survival with mastectomy. There is an increased risk of complications. There is no evidence of better patient-reported outcomes. It increases the need for whole breast reconstruction. The implications of reconstruction and interaction with RT, I'll come towards the later part of my presentation. And lastly, it increases the individual and societal costs when you consider reconstruction options. Now, the first step to eliminate mastectomy is to realize that breast conservation is the standard of care. We know of all these landmark trials in the 20th century which showed that breast conservation has equivalent survival to mastectomy. But in the 21st century, albeit we don't have a big randomized control trial and I don't expect one to come, we do have data from large studies, observational, which show a remarkably consistent benefit to breast conservation therapy with regards to survival outcome. Of course, there may be a lot of confounding factors involved as well. But the key point here is that any cancer, single or multiple, that can be excised to clear margins before or after neoadjuvant therapy or oncoplasty alone or in combination and leaves a satisfactory cosmetic outcome can and should be treated with breast conservation. However, we do have a very small category of patients who are still best treated with the mastectomy. If you exercise the full extent of oncoplastic surgical options that we have, practically it boils down to three indications. Number one is young patients who are having germline genetic mutations. Number two are patients who are not responding to a neoadjuvant chemotherapy and are progressing on it. And number three is diffuse multicentric disease in the breast. Now, with that prelude, when you look at the eligibility of this trial that we are discussing, SUPREMO, you look at all these PT1, PN1, PT2, PN1, all these patients in the current era would most likely go for a breast conservation rather than a post-mastectomy RT. So if we talk about external validity of this trial and the clinical implications of this trial, we are in an era where the eligible patients in real world practice who would go for this trial criteria is diminishing by the day. This is especially because breast conservation has shown a lot of advantages which I have previously enumerated, and it is reflected in almost all the major oncology consensus like the St. Gallen, where they have mentioned that patients should be advised that breast conservation and radiotherapy is usually the best treatment option, as opposed to an earlier era where we used to say and counsel to our patients in our clinics that you have option of breast conservation versus mastectomy. Both are equal in terms of survival. It's up to you to choose. Now, it's imperative that the clinician advise the patients that the best treatment option in early breast cancer cases, at least, is breast conservation. Now, what about axillary staging? This is from the inclusion criteria of the SUPREMO trial. If the axillary node positive cases with a low axillary burden, almost all of them had axillary node clearance. Now, is this contemporary practice? No, because the guidelines have clearly come to recommend that even for a 1 or 2 sentinel node macrometastasis, it is safe to omit axillary lymph node dissection in patients with clinically negative axilla who have undergone sentinel lymph node surgery. Now, where does the evidence for that come from? These are the recent large trials which forms the evidence base for this recommendation. The Z11, the Amoros, the Otavasor, Synodar-1, and the Sinomac being the latest. The few points in this table which I would like all of us to focus on is the number of cases which were included in these trials who underwent mastectomy. Now, these trials most of the times included patients who had a primary tumor resembling what was included in the SUPREMO, but only around 20% of these patients, except in the Sinomac, had undergone mastectomy. And the main axillary treatment modality of a sentinel node biopsy has given a very good overall survival benefit with a very low axillary recurrence rates at 10-year follow-up. Now, this has been reflected in the most recent ASCO guideline update on management of axilla, where even for mastectomy with 1 to 2 node positive, the recommendation is not for axillary dissection, and rather we are favoring more of axillary radiotherapy. So that brings us to the point where the surgical management with regards to the breast in this trial also actually is not exactly matching what we see in the real world, as well as the axillary staging is also not in tune with the contemporary practice. Now, the second important point I would like to make is the fact regarding breast reconstruction. The cornerstone of breast reconstruction, which must be offered to all patients at the time of initial discussion regarding surgery, is to restore cosmesis and improve physical and psychological health. Now, this is a large systematic review published recently. And if you look at the main outcome from this systematic review, you can see that the top part where the patient-reported outcome measures as assessed by the BreastQ scale is showing a clear benefit for patients undergoing breast reconstruction as opposed to patients without reconstruction in all domains. So the decision of the type of mastectomy and the reconstruction should be discussed in the preoperative MDT with appropriate assessment of potential need for a post-mastectomy radiotherapy. Now, why is this relevant? Because radiotherapy influences the type, the timing, and the complications and outcomes of breast reconstruction. Which brings me to another fundamental question: what is a mastectomy? A mastectomy is a surgical procedure where we aim to remove all the glandular breast tissue without impairing the viability of the skin flaps. Now, if you actually look hard at the science behind it, the figure below shows the demarcation between the dermis and the subcutaneous adipose tissue, and the star mark actually shows an extension of the glandular tissue into the subcutaneous tissue, which goes very high up, almost up to the level of the dermis. And the plane of dissection that in mastectomy that we follow is somewhere very variable within this layer. And understandably, it is bound to leave behind some residual glandular tissue. Now, a simple mastectomy, this fact was realized almost a century ago. When in this publication by Frederick Hickens in 1940, he has commented that in simple mastectomy is an operation which is frequently attempted but seldom accomplished. And in 95%, 94% of the mastectomies, the skin flaps contained residual glandular tissue. So what is a mastectomy today? Today, we are moving away more from the modified radical mastectomies and simple mastectomies to more of skin sparing and total skin sparing mastectomies, which is likely to leave behind more breast glandular tissue rather than simple mastectomies. And in the context of the prepectoral implant reconstruction, which is most in vogue now, this tempts the surgeon to leave more tissue behind in the mastectomy flaps. And the discussion of avoiding post-mastectomy RT in such a scenario needs to be taken with a pinch of salt. Now, this is a slide courtesy of Jana de Boniface, who has written a beautiful editorial for the SUPREMO trial in NEJM. She's a surgeon from Europe. And you can see she has shared one of these patients which illustrates this point. You can see that in the mastectomy flap above the implant, there is quite a lot of significant residual glandular tissue left. Now, which leaves us hard pressed to think whether it's safe to actually avoid post-mastectomy RT in this type of reconstructions. Now, regarding the timing of post-mastectomy RT and the reconstruction, a lot of surgeons actually are not comfortable doing immediate reconstruction for patients for whom post-mastectomy radiation is anticipated because of the increased complication rates. So mostly they go for delayed reconstruction or delayed immediate reconstruction, where the mastectomy is done first, followed by RT, and then a waiting period of 6 to 12 months, followed by breast reconstruction. And in the delayed immediate, there is an intermediate period where you use a tissue expander and then go for radiation, and then go for reconstruction followed by radiotherapy. Now, the point to be remembered here from a real world point of view is that in an Indian scenario, it is very difficult for patients to come back repeatedly for these procedures or wait for these many this much of time and then come back for a delayed reconstruction, even if they actually were keen on getting a reconstruction upfront. They after a period of breastless period, you could say most of them get adjusted to that state, and they don't end up receiving the reconstruction that they originally desired. Now, what about the complications post-reconstruction and the impact of radiotherapy? If you look at this, this is a large study, mastectomy MROC consortium data, which clearly shows that in when post-mastectomy RT is brought into the picture, both implant-based and autologous reconstructions are associated with the increased complications. The complication rates are more for cases of implants. The fact remains, however, that most of the reconstructions world over are still implant-based reconstructions. So the results of this trial definitely have an implication on that aspect. Now, if you look at the patient-reported outcome measures, which is a key principle I mentioned earlier, the irradiated patients, especially the irradiated alloplastic or implant reconstructions have a decreased satisfaction in all the domains. So this is what I mentioned earlier. A planned radiotherapy sometimes prompts surgeons to abstain from immediate reconstruction, which causes a breathless wait on the part of the patient for delayed reconstruction. And it also increases the need for autologous tissue-based reconstruction. Now, if you think from a practical point of view, the gold standard tissue-based reconstruction is a DF flap or a free flap. And even in developed countries, it is not very accessible to most patients in a timely manner. So the key takeaways from a surgeon's point of view here is that the SUPREMO trial results have brought about a paradigm change in the use of post-mastectomy RT for intermediate risk breast cancer from a routine application to a selective application. And adequate axillary surgery is essential for the application of this trial, since optimal axillary staging is critical for maintaining the locoregional control. And this has to be planned within an MDT framework, which integrates several other aspects like tumor biology, systemic therapy, pathologic response in case of patients who go for neoadjuvant therapy, as well as the surgical aspects. There are a lot of interesting de-escalation trials, primarily the T-REX trial, which is also which mandates the omission of axillary node clearance, and the MA39 trial, which will shed more light on this, and the subsequent real-world patient-reported outcome data will also further define which women truly benefit and who are best served by omission. Lastly, the results may be especially reassuring for surgeons who treat patients seeking immediate breast reconstruction if RT can be safely avoided. With that, I go back to the first point, which I would like to reiterate again. This is a patient who has undergone a mastectomy at Premier Institute in our country for an early breast cancer, and when she came back to us with a newly detected breast cancer on the right side, she was already suffering from the aftermath of radiotherapy and its problems for the past 25 years. And now she was at a loss as to what to do on the right side. Now, if applied properly with oncoplastic principles, this is what you can attain for these patients without mastectomy or without even reconstruction. She just has a good breast on the right side. So this was a flap reconstruction using an LTAP flap, which is a common volume replacement technique that we use. So that's all from my side. Thank you.
Thank you, Shafeek, Dr. Shamsudeen, for another masterclass. I can't imagine how to communicate this to the patient easily. It must be quite daunting to explain all of this and get a patient to understand it.
Yes,
But that was very, illuminating. And I think all three of you have produced a common thread here. Now I'll wait to see what Dr. Gulia has to talk about the medical oncology part of this this manuscript. Shafeek, you can stop the screen share, actually.
Okay.
Dr. Gulia, over to you.
Yeah, hi, good evening. Thank you, Dr. Matthew, and my apologies. I was not aware that I have to prepare the slides for this general club. So
that's
as
okay.
a previous...
There was no requirement, actually. You're fine.
Yeah. So if I have to summarize the results of SUPREMO trial in one line, it would be that this trial results are not applicable in present era, because we are in the era of personalized therapy and biomarker-driven treatment. There is not a focus on the de-escalation of therapy for breast cancer particularly, and the reason being there is significant improvement in the outcome of breast cancer over last 1 decade, and this has already been highlighted by the previous speaker. If we look at the outcome of breast cancer per se, it depends primarily on the tumor size and the nodal status. Age, premenopausal status add to this. There is significant de-escalation in terms of radiation therapy and surgical treatment. We have moved down from axillary lymph node dissection to sentinel lymph node biopsy, and now there is more and more upsurge in avoiding surgery altogether. And this has been possible only because of improvement in systemic therapy. So because there is significant improvement in systemic therapy, be it chemotherapy, immunotherapy, or the targeted therapy, we are achieving more and more pathological complete response. And this is making sure that probably we may talk about avoiding breast surgery at all in future. If we talk about the T1, T2, N0 and N1 patients per se, the systemic therapy discussion cannot happen without dividing these patients into three subgroups. These are hormone receptor positive, triple negative, and HER2 positive breast cancer. In hormone receptor positive breast cancer, we are avoiding chemotherapy in patients who are either node negative or 1 to 3 node positive, strong hormone receptor positive, based on the RX Ponder as well as the Mindex trial and the TaylorX trial. So we are de-escalating chemotherapy as well. If we talk about HER2 positive breast cancer, there also we are reducing the duration of chemotherapy. We are moving towards avoiding anthracycline-based chemotherapy, particularly in patients who are T1, T2, and node negative. And the long-term follow-up data of trials like APT trial have shown remarkable results where the DFS rates have been reported as high as 93% at 7 years. Similarly, for triple negative breast cancer as well, we are discussing about omitting chemotherapy there as well. And this is particularly in patients who are T1 node negative and who have high stromal TILs, which is, there is no consensus on the percentage of stromal TILs, but various studies have shown that patients who have more than 30% of TILs in T1 and 0, we can avoid chemotherapy as well. There is a paradigm shift in the way we treat breast cancer. Earlier, patients were taken up for surgery upfront, but there are studies over last 1 decade which have shown that there is more and more uptake of neoadjuvant systemic therapy for breast cancer, especially for patients where tumor size is more than 2 centimeter, even if they are node negative. And this is particularly true for patients who are HER2 positive or triple negative breast cancer. So we are trying to de-escalate the treatment in terms of surgery, radiation therapy, as well as systemic therapy. And this de-escalation is predominantly dependent upon the patient-related factor as well as the tumor-related factor. So one size does not fit all, and the treatment of each individual is highly individualized, and that has to be decided based upon the biomarkers that are available.
Thank you, Dr.
Yeah, that's all
Gulia.
from my side. Yeah.
Yeah, thank you. Floor is open for questions if there are any or comments while we wait for somebody to put up with a question. Let me ask Dr. Beriwal this question that I have in my mind. How much has genomic testing been used in clinical practice in North America? For instance, Oncotype DX for that matter, or something else? Is something in terms of guiding determining whether radiation is indicated?
So, for now, the both Oncotype or Memaprint is used for deciding about chemotherapy, uh, uh, both for node negative and node positive disease, depending on premenopausal and postmenopausal status. For radiation therapy, we don't order it. But that being said, if somebody has Oncotype DX testing done and they are 1 to 3 node positive, we do take that factor into account in deciding about it. So somebody is high Oncotype DX, T3N0, or high Oncotype DX with 1 to 3 positive node and has full dissection done, then we'll take that factor into account. But because it's only retrospective data, prospective data is lacking. It's part of the ongoing study which has completed and will have the answer in probably next 5 years or so. It's not ordered specifically for that, but it is taken into account in decision making if that is available. Now, but on this note, I just want to emphasize that even though the guideline says that for sentinel for biopsy positive 1 to 2 node dissection should not be done, I commonly see in India people still getting dissection done. So that information, that knowledge is not as democratic as we would like it to be. I still see across the country, when I see different practice pattern, people presenting case-based discussion, I still see people getting dissection done. So that information is still not democratic as it need to be. The number of women with 1 to 2 center for biopsy positive who undergo dissection is not zero.
But I want to pull up Shafeek into this discussion. Sentinel node biopsy, as Dr. Beriwal is describing, is actually using two-dye strategy, right? I mean, to reduce the false negativity rate. How much applicable is that in an Indian context? Or are we at risk of under-treating if we apply the same principles to some of the single-dye sentinel node assessment?
Actually, I don't think so. Because there are enough evidence now which shows that in an upfront surgery setting, definitely in the post-neoadjuvant setting, perhaps a dual dye is an absolute requirement. But in the upfront surgery setting, there is a lot of promising data which says that a single dye, if validated in one's practice, is good enough, especially with the advent of ICG, indocyanine green. Fluorescence has been a big game changer in this regard. Unfortunately, it's not as popular in Europe and UK as it is in Asia. But as a single dye, ICG or its low-cost alternatives like sodium fluorescein, which is actually cost much less than ICG, can be done even in remote rural areas. So there is a lot of data coming from India, which is published in good journals, which reassure us that a single dye is good enough in resource limited settings. In fact, one of the studies on de-escalation of post-neoadjuvant setting was using from Carla Ribeiro Fontana from the European Institute of Oncology, which gave 10-year survival results, very good results, was using a single tracer. So that was even in a post-neoadjuvant setting. So I think that should not be a deterrent in India, and I don't think it is anymore true that it is a deterrent.
Yeah, so what I'm noticing is like there are two aspects. One is access to center for biopsies, which is one aspect, and second is you do center for biopsy and it's positive. That's the second aspect. So first aspect is the access issue, which I understand it's not same across the country. The second aspect is the knowledge issue, which I don't think it's as democratic as it needs to be. I still see breast surgeon across the country. As soon as they see center for biopsy positive, doesn't matter if patient has lumpectomy or mastectomy, they do dissection. So I think that information is not as democratic and as widespread as need to be, because I think they're still in the old mindset that dissection is important. And Dr. Shamsudeen can vouch for it, but I know you go across the country in different meetings and all, and you do still. I mean, we recently did a workshop in Calcutta with case-based discussion, and cases were presented from all across the country, and I commonly saw that theme. They had dissection done.
Yes. So the second part, I was mainly answering to the first part. The second part, I completely agree with you. There is a lot of practice variation across India. If you see the corporate setup and academic institutions, there is more of true de-escalation in the axilla for a positive note, for a low burden axilla, following the guidelines that we have available. But in the periphery, most of the times it ends up being an axillary dissection. So this has reflected in a large practice-based survey study done by APSI, which has also shown that majority of the surgeons were actually going for axillary dissection when the nodes were positive. So that is something which is a fact.
Pardon me if I'm asking a stupid question. Is this hyperfractionation thing? If you're doing BCS 5 fractions, is that something that can be considered for this kind of a post-mastectomy radiation as well?
So the fast forward study, which is looking at 3 weeks versus 1 week for post-mastectomy radiation therapy, including regional load, has presented 3 years data about morbidity and have shown non-inferior morbidity. But we need outcome data for the fast forward in terms of local regional recurrence, disease-free survival, and overall survival. So currently, that 5 fraction treatment in our own practice is standard of care for early stage breast cancer. So if you're not doing regional load, in our practice, you have to justify doing even 3 weeks treatment. So people, when they present their cases, we have mandated to the extent that even once you go beyond 5 days, you have to justify why you're doing it for early stage breast cancer. But for post-mastectomy, regional load, it is still a 3 weeks treatment. But that being said, that's another aspect I noticed in India. Like patients who have undergone lumpectomy for early stage breast cancer, I see reluctance to even offer 5 weeks treatment, 5 days treatment. I commonly see 3 weeks treatment. I've reached out to radiation oncology and they say we don't feel comfortable. And I'm talking about major tertiary care center who have resources to be able to do things correctly. But that being said, the adoption of 1 week treatment is not as good as we would like it to see in India. Part of it could be driven by practice pattern, part of it could be driven by comfort level, part of it could be driven by lack of data in Indian setting. But when I say I'm talking about early stage breast cancer, I think somebody has hand up, Bindu Venugopal.
Yes, you can unmute and ask your question, Bindu.
Hello, thank you to all the speakers for such a comprehensive and critical look into Supremo trial. My question is to Dr. Sushil Beriwal. So I'm a radiation oncologist who's practicing in a tertiary institute in the public sector in the south of India. And we very often come across patients who are not as well nourished as the Western counterparts. So they end up not receiving the complete number of cycles of chemotherapy or the dose that is actually recommended. So in such a scenario, how should we, in an MDT, base our decisions in the light of Supremo inclusion criteria?
So to answer your question, for those who don't meet the ASCO guideline, I would not offer them. So if it is T1, T2, N0, or if it is T3, N0 with lack of adverse factor, doesn't matter what systemic treatment has been offered, I would not offer them. But for N1 disease, if they do not get systemic treatment, then you could make an argument that local regional treatment may have higher impact. We don't know the data because we are extrapolating or speculating. But that being said, in the N1 disease setting, lack of or completion of adequate systemic treatment could be one of the reasons to do it. But you cannot create any new indication in the absence of indication. That's what I want to emphasize. If there is indication, that could be one of the factors. But if there is no indication, I would not take that as indication for T1, T2, N0 or T3, N0 or for micromets.
So I think
the same would go for HER2. Sorry. Would the same go for HER2 positive patients, because the state doesn't cover in its program trastuzumab, so the patient has to pay out of pocket, and a lot of times they don't receive it in entirety. Should we be looking at offering them radiation in lieu of the number of cycles of chemo missed?
For example, the only thing I consider in patients who don't get anti-HER2 therapy is I would be reluctant to do partial breast in them and do whole breast, but I would not make that as an indication for post-mastectomy for N0 disease. Now, once somebody asked a question in the chat about SKECKING trial. So there are about 5 prospective randomized trial of regional node with hypofractionation versus conventional fractionation. These clinical trials are the Chinese data, the hypo-IG data, and almost all the studies have shown non-inferiority except for the SKECKING trial. And there is no difference in local regional recurrence pattern, but there is difference in breast cancer survival at like 5 years follow-up. And I feel that could be potentially because of mismatch in terms of disease profile demographics, which are sometimes hard to account for in the outcome data, because you don't expect hypofractionation to decrease survival in 5 years. I mean, there is no way you can make that as an argument when it has not shown to make any difference to the outcome in terms of disease-free survival and overall survival for any one of the endpoints in any one of the post-lumpectomy clinical trial of hypofractionation. So I don't use that as an argument. I feel there is enough data that hypofractionation is the way to go for both post-mastectomy and post-lumpectomy setting. The SKECKING trial did show decrease in survival, but I don't know whether that's because of treatment. I feel it's more because of probably mismatch of disease profile than the treatment itself, because I can't even think about a way hypofractionation would cause increased mortality.
Thank you, Dr. Beriwal.
Thank you, Dr. Eapen, Dr. Beriwal, and Dr. Shamsudeen, and Dr. Gulia for this wonderful journal club. I learned a lot. Of course, there are more questions that remains to be answered, but I think the conclusion that all of you have presented is that this the final conclusion of the study should not be just read out of the abstract, but it's in the details, and that the design and the time duration of this conduct has changed in the clinical practice currently, that we have to relook this the conclusions from the Supremo trial in light of the current practice and adapt it to the kind of patient that you operate or that you see based on the tumor size and the presence of nodal status. Excellent presentation. We'll host this on YouTube soon. But thank you, Dr. Eapen, Dr. Beriwal, Dr. Shamsudeen, and Dr. Gulia for this very insightful 1 hour of Journal Club discussion on Supremo trial. Thank you.
Thank you.
Thank you for inviting, and thank you for this discussion. Thank you all.
Thank you for the opportunity. Good night, everyone.
Thank you.